Good evening, everyone, and welcome to Guiding Light, Navigating End-of-Life Care for Head and Neck Cancer Patients. This is a webinar presented by the Head and Neck Cancer Alliance and the American Head and Neck Society. Welcome to you all. I'm Dr. Susan McCammon. I'm the Director of the Division of Head and Neck Surgical Oncology at the University of Alabama at Birmingham, UAB. And I am joined by two of my partners, Jackie Palmore, one of our nurse coordinators, and Monica Thompson, one of our chaplains and spiritual leaders. Thank you for joining us for this compassionate and informative webinar that's tailored to individuals and families facing the challenges of end-of-life care for head and neck cancer. We are also joined tonight by caregiver and surviving spouse, Ellen Bernstein Ellis, who has walked this journey with her late husband, Steve. Our hope tonight is to share practical advice, valuable insights, and support for you all by addressing crucial topics like pain management, financial planning, emotional support, spirituality, and practical advice for patients and their loved ones. Our goal is to provide essential information and cultivate a sense of community. Thank you again to our panelists for joining us today to share feedback and answer questions from the webinar audience. I encourage you all to write your questions into the Q&A box, and we will address them at the end of the panelist introductions. Now I'd like to introduce the folks who are joining us. I'm happy to work with Jackie and Monica at UAB, and I've been delighted to get to know Ellen through working on this webinar. So Jackie began her nursing career working in oncology and critical care and transitioned to home health and hospice in 1990. Before joining the UAB Center for Palliative Care in 2004, she served as a hospice director for a local hospice and worked with two other hospices in the Birmingham area. She implemented the first prison hospice system for the state of Alabama in 2001. As a palliative care coordinator, Jackie collaborates with the palliative care team every day. She assists with hospital consultations, and she acts as a critical liaison for the palliative care program within the hospital and community. She also coordinates and follows up with patients referred to hospice. Additionally, she's a certified end-of-life nursing education or LNEC trainer and a certified hospice palliative care nurse. Thank you for being with us, Jackie. Monica Thompson, Reverend Monica, is the spiritual care manager at the UAB Center for Palliative and Supportive Care and an ordained minister in the African Methodist Episcopal Zion Church. She began her journey with UAB as the oncology chaplain and became a board-certified chaplain with the Association of Professional Chaplains. In 2015, Reverend Monica Thompson was appointed as a staff chaplain at the Kirkland Clinic of UAB Hospital. She primarily serves oncology patients in that role. She has been awarded a Medical Excellence Award, well-deserved, by UAB Medicine, which honors healthcare professionals who embody exemplary core values, service, and outstanding care. Thank you also, Monica, for being with us tonight. Now I'd like to introduce our special guest, caregiver survivor, Ellen Bernstein Ellis. Ellen and her husband, Steve, were high school sweethearts and soulmates, sharing a wonderful life together. They raised two children, Jennifer and Ben, and eagerly looked forward to becoming grandparents one day. In 2018, at the age of 61, Steve was diagnosed with both a benign cerebellar hemangioblastoma and a sinus mass. That sinus mass was later found to be a salivary gland cancer that had spread to several other areas. He underwent a challenging treatment regimen that included 2 surgeries, radiation, chemotherapy, physical therapy, and speech therapy. His treatment spanned nearly a year before he entered hospice care and passed away in July of 2019. Steve was a shining spirit and an incredibly caring and courageous partner and father throughout his life and cancer journey. He is dearly missed, but his memory continues to be a blessing to many every day. Ellen has worked for many decades as a speech-language pathologist and is currently the director emeritus of the aphasia treatment program at California State East Bay. Please welcome with me Ellen Bernstein Ellis, who will share her story to get us started.
Thank you. Thank you so much for the kind introduction and for inviting me to be part of the panel. This is the hardest of topics, and I want to normalize and validate your experiences, your feelings, offer some tips and some hope by sharing our journey. I hold in honor that every family dealing with head and neck cancer watching this webinar has a unique and special story. Steve captured my heart at age 16, and he became my rock and lifelong solid partner. I read a blog just last week that quoted the writer John Binkley, who found solace in writing letters to his spouse after her passing. In one of those letters, he said, "You gave me so much love for 46 years that it has fueled my recovery from the loss of your companionship." That deeply resonated with me, and I'm here today because I have found that the power of love is sustaining. Here's our family through the years. Steve cherished being a dad, and he filled our family with an abundance of love. Our incredible family and friends rallied to help pull together a beautiful wedding for our daughter Jennifer and her beloved David in just 3 short months. But Jen wanted her dad there and picked a date that would likely be between his treatment cycles. It wasn't easy for Steve to talk due to severe trismus. He could only open his mouth a little bit, but he practiced a lot and had support from his wonderful speech therapist, Dr. Heather Starmer, and he delivered an amazing toast at that wedding. Steve did pass just a few months after the wedding, but for a year, Steve received expert and compassionate care from Stanford Medicine healthcare teams, including neurosurgery, head and neck cancer, and the palliative care groups. I wish I could call out the names of all of his providers as they walked the journey with us. They had the remarkable capacity to be present to both our medical and emotional needs. I've broken up the talk today, this short talk, into 3 sections: what I wish I'd known, what I'm glad I learned, and what I hope for you. So, what I wish I'd known medically. Ask your oncologist before the transition to hospice what scenarios you might be facing at end of life. Head and neck cancer is less common, and your hospice agency may have limited familiarity with it. I wish I had been better prepared. A conversation with Steve's doctor might have helped. Clarify with the medical team for guidelines about accessing their support after the transition to hospice. Just ask. Ask if you can call or email if you have a question. I didn't realize I could do that. There are unique swallowing, communication, and medical issues related to head and neck cancer that can arise. So it's just nice to know that you have some expert backup. Ask if your hospice team has a speech therapist on board. If not, strategize how to get the information you need for best care. Speak with the medical team and/or hospice about best practices for discontinuing tube or pump feedings when it's time. Now, not everyone with head and neck cancer needs a feeding tube, but Steve did, and we struggled with that issue. I was so focused on how to best maximize Steve's comfort, and I wanted assurance that there was a good plan in place. So it's an important conversation to have. Do whatever you can to advocate for your loved one. You may not always get the answers, but that's beyond your control. Sometimes weird symptoms come up with head and neck cancer, and it's hard to find a solution or to fix it. But I learned to accept that we can just do the best we can do. How about I'd like to share some things about what I wish I'd known practically too. So this first one is really important, and I hope it will be helpful to somebody out there. If you are a head and neck cancer patient who is still actively employed and have a pension, then please ask your HR or pension manager, will I lose a percentage of the pension payment if not retired at the time of death, even if fully vested? So Steve was a brilliant numbers guy, and he knew his stuff, but he didn't know that I would lose 50% of the pension payment he expected me to have to help provide, because he died 3 days before his retirement date. Please ask and document when you talk with HR. His company's web-based pre-retirement checklist that Steve followed to a T just did not address this issue. Check what will happen to your credit card accounts if the loved one is primary. Be prepared to lose access to the account once death is reported. So Steve was primary on our main family card, and within, I think, a week to 10 days, the bank was notified about his death, and they froze the account, which was okay, except I couldn't access it even online, so I couldn't get past statements, and I certainly couldn't verify all the charges that we had for that month. So it's an okay thing, it's manageable, especially if you can prepare a plan for that. I want to share that it can be hard to manage your expectations for all the last, like the last anniversary, the last holiday, the last birthday. So just be gentle with yourself. It's really understandable if your loved one just doesn't feel up to participating in those special dates in the way you hoped. Be gentle with yourself as you navigate those feelings. Get help navigating grief through counselor groups. You know, sometimes in trying to protect each other, you may miss opportunities to grieve and heal together. And I'll just share, frankly, that's something I know I'm still working on with my adult children. So I thought I would put it out there. I'm going to share some things that I'm glad I learned. Be ready for changes in social preferences. Often the world and what matters narrows. So what was okay socially in terms of visits or activities one day may really change the next day. And just be sensitive and attuned to that. Be ready to make those changes. Here's a real practical tip. Renting one of those recliners with a power lift seat can be really useful. It allowed for us to keep Steve in the center of our activity in our big room, and it allowed him to have more independence and autonomy, and it helped me as a caregiver. So just a practical small tip. Initial hospice intake can be an overwhelming flurry of activity, but I just want to assure you it settles down and they will meet you where you need to be at. I also want to share that acknowledgement from the medical team can be profoundly healing. I cherish the letter that Steve's oncologist, Dr. Caregiver, sent us offering his condolences. And when I finally had the courage to walk back into the head and neck cancer department to return some supplies, word quickly spread that I was there. And despite really busy patient schedules, his care team somehow managed to dart out into the waiting room and surround me in a hug. And their support was just so healing. I also want to share that those tidal waves of grief, well, they eventually change to sneaker waves. And even those sneaker waves get spaced out more and more as time goes on. Here's what I call the spaghetti bowl model of grief recovery that I received in my loss of a spouse grief group at East Bay Hospice. Understanding that my journey through grief was not linear sure helped me to better cope with the process. I have a few things that I wish for you too. I wish that you have success in having these hard conversations. And there's a nonprofit, Planning My Way, that offers a tool that's really thoughtful and helpful in guiding those discussions. Discuss how to access the support you'll need to maximize communication and participation. I want to keep the person with head and neck cancer central to participating in their medical decisions and medical care and being able to communicate it. And that's why I think speech pathology services are so important. Understand the end-of-life scenarios and strategies to provide support and comfort. Your hospice team will be expert at that. If it means crawling into the hospital bed and holding each other, that's great. If it means holding a hand, playing music, there should be a large range of strategies that will help you stay connected and be meaningful. Reframe. So rather than getting over grief researcher Dr. Cacciatore suggests it's a process of building your coping and resilience skills, and that really works for me. Learn to be intentional about milestone dates like birthdays and anniversaries. My very wise and young niece, who lost her husband from a rare cancer the month before Steve passed, she taught me about being really intentional and thinking about what I need those special days to look like, how much time alone, how much time with family and friends, where I need to be. And when I shared that sometimes the day after a birthday or anniversary was even harder, she just said, yeah, you have a grief hangover. And just understanding that helped me to cope so much more effectively and productively and constructively. Find a support group, a counselor, perhaps a Facebook group, but just normalize and validate what you're feeling and build a team. You do not have to do this alone. Finally, I want to share a quote that I have found comforting. It's by Elizabeth Kubler-Ross. The reality is that you will grieve forever. You will not get over the loss of a loved one. You will learn to live with it. You will heal, and you will rebuild yourself around the loss you have suffered. You will be whole again, but you will never be the same, nor should you be the same, nor would you want to. So thank you so much for letting me be part of this panel, and I'm honored to pass it on to the other two speakers. Thank you again.
So good evening. I'm glad to be here with you this evening. I'm Jackie Palmore, and Ellen, thank you so much for sharing the beautiful story and your insights and the things that you've learned and the things you wish you had known. And so what I'd like to do this evening is talk to you a little bit about hospice care and what that might look like when you're facing end-of-life decisions, and that this may be an option. And this is a definition from the National Cancer Institute and talks about it's a program that gives special care to people who are near the end of life. These are people that are no longer seeking aggressive treatment or curative treatment, generally with a prognosis of 6 months or less. And, you know, that is just a ballpark. When I say 6 months or less, that's a Medicare guideline. But this is really focusing on quality of life, addressing physical, emotional, social, and spiritual support for patient and families. And it's really about focusing on comfort, controlling pain and symptoms, just helping support that patient and family in the home. So, and usually hospice care is going to be provided in the patient's home, their residence. It could be in a nursing home, assisted living, independent living. Some places have inpatient hospices in the country where they live or in the states where they live. So what I want to talk about on this slide is, what does hospice provide? What services do they provide? And it's a team approach. And so you're going to have doctors and nurses, home health aides to assist with personal care, chaplains, social workers, volunteers, and these are people that come together to support the patient and family. Hospice, they're not in your home, they don't stay in your home, but they're there several times a week, checking in, assisting with personal care, making sure symptoms are managed, and they're coordinating all this care as a team. Again, focusing on quality of life, so important. I like to use the word aggressive symptom management because managing symptoms is so important, and we're going to talk a little bit more about that. Again, that added layer of support. And one of the things that I think is so key to hospice, that it's available to you 24 hours a day, 7 days a week. So when you have that problem or question that comes up at 2 o'clock in the morning, you know, reaching out to that hospice, they can come out at 2 o'clock in the morning. You're not waiting for the doctor's office to open or taking your loved one back to the emergency room or calling 911. So being available 24 hours a day, to me, is that safety net that really benefits our patients and families. And hospice services are covered by Medicare, Medicaid, private insurance. For people that are uninsured, it's covered as well. They're also providing medical equipment. So that would be a hospital bed or a walker or a wheelchair or oxygen or whatever the case may be. All the durable medical equipment is provided by that hospice company. And it pays for the medications that are related to the terminal illness. So that would be things like the pain medication or symptom management, constipation or anxiety, whatever the case may be, but they're going to cover those medications. And as Ellen alluded to about grief and bereavement, they do 13-month bereavement follow-up, which is very important for our patients and our families. So let's take a few minutes and talk about symptom management. All patients don't experience the same symptoms. Some people are going to have some of these, some people will have none of them. But these are things I want you to be aware of. And when we talk about pain, it's important that we're really on top of the pain. So pain can be, there's so many routes of administration now that we have to do in the home. We have liquid concentrated medications. We have pain patches such as fentanyl. We can crush medications and administer them in small bites of like ice cream or pudding, or maybe in a peg tube if the patient has a peg tube. So there's a variety of ways that we can administer medication. The same with anxiety or shortness of breath. We're using medications to help control these symptoms. When you have pain, anxiety, and shortness of breath, it just compounds things, right? So we want to get on top of those things. So when you have your hospice team there, make them aware of what's going on. Talk to them about symptoms that you may be seeing or questions or concerns. For example, with shortness of breath, we're using low dose pain medications, to help with shortness of breath. It works really, really well. I want to mention about dysphagia or difficulty swallowing, because that can be a challenge. And if a patient is still able to take little bits of food or something, but not eat a meal or swallow large amounts of food, it might be just the taste, like a little end of a spoon, a little bit of coffee, or a little bit of something they really like, a taste of ice cream. Sometimes that can be very satisfying. So being aware of swallowing difficulties and challenges as you're seeing those, incorporating, talking to your hospice team about how best to handle that. I want to mention bleeding, because sometimes with head and neck cancer and with tumor burden, people can bleed and it can be unexpected. So in an effort to be proactive, what I encourage people to do is have dark towels available. I mean, have them there at the bedside, because if someone does have a bleed, the dark towels, it will not be as shocking as if you had a light colored towel present. So that's something to consider. Wound care, sometimes our patients have wound care issues that we need to address. Again, hospice should be helping you with that, showing you how to do wound care, providing you with those supplies. I want to touch on tube feeds and communication in respect for time. Tube feeds, as Ellen brought up, thinking about, when is it appropriate? When do you start them? When do you stop them? These conversations are important to have ahead of time with your healthcare provider, and just thinking through what is important, what are the goals. And at times when people have tube feeds, as the body slows down, it does not need the tube feed. It can't tolerate it. So they may be not absorbing it. They may have abdominal distension, nausea, those kinds of things. So those are conversations about, well, maybe we need to, back off on the tube feed, or it's causing the patient to have more congestion. So those are conversations that are important. And communication is a challenge, when our head and neck cancer patients are not able to communicate. So thinking out loud about, with your family, with your hospice team, having a whiteboard available. I've had patients that communicate by phone. They text the information they want to me, using their computer, writing on a notepad. So thinking of ways to communicate so we can elicit the questions, the concerns that that patient may have. And so lastly, about choosing a hospice, know that you have a choice. In different parts of the country, for example, in Birmingham, we have lots of hospice agencies. Depending on where you are, you may have a few or a lot, but you have a choice of providers. So look into those. You might want to ask your doctor or healthcare provider, do they work with a particular company? Is there a company that does take care of head and neck cancer patients or have more experience? And the other thing I would encourage you is to talk to more than one hospice company, just to get to know them, ask the questions that you have. And lastly, I want to say, don't wait. If you are faced with a terminal illness, don't wait until the very end. A lot of people say, well, I'm not ready for hospice because the patient's still up walking around and caring for themselves. But that may be the time to get hospice involved so they can develop the rapport and establish a relationship. And they're there when you need them. So thank you very much.
Good evening, everyone. I'm Monica Thompson, the Spiritual Care Manager with the UAB Center for Palliative and Supportive Care. And I would really like to thank our caregiver survivor, Ellen, for her beautiful, beautiful story that she shared with us. So guys, I'm going to briefly be talking about spiritual care issues at end of life. So first, many of the issues become very existential, the existential suffering that our loved ones experience. They may be questioning, what is the point of life? They may be trying to seek meaning, validation, or purpose at this particular point. They may want to feel comforted by hope. They may be very hopeful. Oftentimes, it's a bit of a psychological struggle. The helplessness they feel, the hopelessness they may be experiencing, as well as the worthlessness, concerns about being a burden to the family. I don't want my kids to have to care for me like this. I don't want my spouse to have to go through this or to experience this with me. And again, questioning their self-worth. Where is my worthiness to be found at this point in my life? Next, for those of us who have a religious orientation, it may be some form of spiritual suffering that could be happening. They may be questioning their faith with God. They may be wondering, where is God in the midst of their suffering? They may be struggling with their community of faith. They may be getting mixed messages from their community of faith. Some, perhaps well-intentioned members from their community of faith may be saying to them, well, you're not praying enough. You're not trusting God. Where is your faith in the midst of all of this? While they may be well-intentioned, not helpful for those persons in that family or that patient to really hear. For many, faith can be a source of meaning and a source of peace. Utilizing sacred literature, prayers from the different faith traditions, incorporation of spiritual music, all of that could be very meaningful, very rich, very dynamic for all of our caregivers and their loved ones. It could also be social and relational concerns, where the patient may not be concerned about themselves, but they're more concerned about the members of their family system, their caregivers, their loved ones, their extended community, making sure that everyone else is okay in the midst of their suffering, making sure that others' needs are provided for. Particularly with our head and neck cancer patient population, isolation and abandonment. Given the particular physical challenges that the patient population experiences, it may be difficult for small children. It may be sort of experiences in the public where people who are just looking and just asking ridiculous questions and concerns. So abandonment, that isolation, the disfigurement that can come with this illness can be very triggering, very isolating for these patients, and can contribute additionally to their suffering. There may also be a desire for peace and reconciliation within that family system. Have all the issues, all of the conflicts been resolved? It may become that patient's responsibility to resolve the conflict, to bring some peace, to bring some healing within that family system as they continue to transition throughout the treatment journey. And finally, I'm sharing with you a series of life review questions that can be very helpful to ask these patients, very helpful for them to sort of explain or walk through. It may give voice to their particular life story. You're empowering them by giving them the opportunity to share their life story. How have they met any of these questions? The stories, the comments after these questions will be very empowering for people to answer. That may help resolve much of those spiritual issues that I've already lifted up, may help give the meaning, that validation, the purpose. Yes, there was a reason for this life journey, and this is what I was able to accomplish in this life. Next, we have several resources here that I think our virtual producer will also drop into our chat. And so I will stop at this time and we will invite your questions. Dr. McCammon?
Thank you, Reverend Monica and Jackie and Ellen. We wanted to make sure that we kept plenty of time for your questions tonight, because this is a challenging topic, and one that you don't get a group of people together all that often to talk about. People who have personal experience, bedside experience with the hard parts of this. So I encourage you to type your question, no question too big or too small, into the question Q&A box. And I will start with the first one. Does supportive care, palliative care, and hospice serve generally the same function across healthcare institutions? If not, what are the differences? Thank you, Ed. Jackie, maybe you could start out with that one. And could I ask all our speakers to come back on the camera?
Yes, I'm happy to address that. So palliative care is going to see people, there are some differences. So palliative care is going to see people throughout the whole disease trajectory, whether they're getting treatment, not treatment. And that is one of the big differences between hospice and palliative care. Hospice, the individual is no longer seeking aggressive treatment. And now they're focusing more on a comfort approach. Now, go back to the question, Dr. McCammon, because I want to make sure I'm addressing the.
Yeah, so we all know there are different labels that institutions use:
Okay.
supportive care, palliative care, hospice. Are they the
Okay.
same, or are they different? What if you find yourself in the wrong one?
Right. In supportive care, we use that terminology a lot with palliative patients. It is supportive care. If you are in palliative care, hopefully that palliative care provider is helping guide you if hospice is appropriate, or having those discussions. So I hope that answered the question.
Great, thank you. I think sometimes people are uncomfortable talking about hospice or even palliative care, and so they turn to, kinder, gentler, more euphemistic terms like supportive care. So I think it is important to really drill down on what's being offered where you are. Next question, is there ever a scenario where the pain medication for a patient in hospice becomes inadequate? Will they need to suffer through the pain without any relief? And I guess
I'll answer
yeah,
that.
go ahead.
So pain medicine needs to be adjusted from time to time. Okay, we do that a lot. We may need to increase the dose, change the pain medicine. But no, for someone to have to suffer through the pain, that would never be the goal. And working with the provider that's working aggressively with you to address the pain is very important.
Yes, and I would add, and then I'm going to ask Ellen, I don't know if you at any point experienced this where adequate pain control was an issue, but our goal is to achieve comfort. And sometimes that's a balance between being awake and in some pain, or being out of pain and being asleep. And as you get closer to the end, sometimes you sleep more and more because that's what it takes to control the pain. But it's a discussion between the patient and the provider and the family about what your goals and priorities are. But we are there with the medication to ease the pain. Ellen, do you have anything to offer?
I'm just going to agree with you that it is an ongoing discussion, and to communicate with your medical team, your hospice team, your medical team, and keep adjusting and balancing what you said, the need between being awake, being asleep. So it's an ongoing balance.
Yeah. All right, next question. When a parent is moving to hospice but is not near death necessarily, what advice would you give in terms of what both parents say to their teenage children, i.e. in terms of how open should one be regarding what's happening? It's a great question. Reverend Monica, maybe you can start out with that one, because that really cuts at the heart of family relationships and hope. Yeah,
absolutely. So I think depending on your particular family system and the developmental levels of your children, the age, what's age appropriate to discuss with them. If you've been very open and honest with them throughout the journey thus far, then continue in that same vein. If you think this information will be very triggering, by all means, consider children counseling in your area. Here in Birmingham, I know we have a children's counseling facility that works very close with family systems, with persons who are experiencing illness. So what are the resources that are available? Are school counselors able to assist your children in this journey as well? So utilizing your resources to help you in this journey, so you won't feel like you're by yourself, and your children will also feel like they have resources as well. I hope that answers your question.
Great. Now we're starting to get questions in Q&A and chat, so I'm balancing. I wanted to just circle back to the pain management question because this is really important. The whole question of insurance coverage can be critical in the stress as you get towards end of life. Is adequate pain management a concern if the client does not have health insurance? Jackie?
With hospice, no, they, because hospices are required to take people that are uninsured. If they're not on hospice, it would be looking, talking to your provider or a social worker, finding means to help you get pain medicine. And there are a lot of medications that are not expensive. So, I hope that answers the question as well. But yeah, adequate pain management is very important.
All right. And then continuing on from that question of resources, when a patient is single and living alone, does hospice or another service provide in-home support as life gets too difficult, or do they move to some type of center before hospice support?
So that's going to depend on what part of the country you live in. If you live in an area that's fortunate enough to have a residential type hospice, that would be wonderful. We do not have them in Alabama. But if you live alone and you're faced with the terminal illness, unfortunately, insurance does not pay for that. Now, some people have some type of long-term care policies that incorporate having sitters or help in the home, but mostly it's out-of-pocket expense to have sitters or caregivers in the home.
Thank you, Jackie. I think that's a really critical question because I do meet a lot of patients who believe that there is a hospice house or a facility where they will move in, and in many parts of the country that is not the case. So that is something to plan ahead for. Okay. A question about any of your experiences in working with racially or ethnically diverse patients and families with regard to end-of-life care issues. I've noticed many communities are not aware of what end-of-life care is, what resources are available, and that this needs a lot more study. Reverend Monica, can you address that one to begin?
Sure. So I think when it comes to minority populations, being very clear about what hospice is, that you have to give a lot of education to the patients, the family system, to the caregivers, being very clear about what it is, being very intentional about these are our goals, these are the aims, this is the FOCI at this point, just being very clear in sort of gently encouraging them to come through. A very aggressive approach to hospice or palliative care will probably turn that family system off as well as those caregivers. But education of it will empower, will encourage better participation. Building that trust and that rapport with them makes a huge, huge difference. And I'm sure Jackie could probably tell 5 million stories.
Yeah, I think we are really lucky to work here with a colleague, Dr. Ronit Elk, who has done a lot with community-based participatory research to really reach into the community, the people and their religious leaders to really try to find out what is the best way to talk about these things without being off-putting or making people shy away from it, and miss out on benefits that they could really use. Okay, let's see. Here's a tough one. What's the best way to respond to my husband when he told me he's going to decline any further treatment if the first round of treatment doesn't help? He's told me not to try to change his mind. He's completed radiation and chemo. He says this is him going through this and not me. We have 3 boys and 2-year-old grandbaby. Of course, we want him to continue fighting. Should I just keep quiet since he said do not try to change his mind? Tough one. Jackie, what are your thoughts on that?
Well, I was going to say, I thought that's a good one for you, Dr. McCammon.
Yeah, I think, you know, a lot of the beauty and value and pain of the last months and weeks of life are what to talk about and how to talk about it. You know, when to be honest and what is too honest, and you know, how to respect the person who's dying while also, you know, being true to your own heart. So my advice there is to just start the conversation and don't shut it down. And when I hear patients say things like this, I hear factual information like I'm not going to do this, and I hear emotional information like this has become too much, I'm ready to go, I don't want any more of this. And so sometimes if you can really get into the emotional content and just say what, you know, what's making you feel this way, it seems like this is really hard, seems very sad. And then as you go further along, you understand that this may be the truest, rightest answer, and that finding a good way to end to a graceful death can be a blessing to the whole family and not purely a tragedy. That would be my response. Ellen, I'd love to hear what your thoughts are.
Well, I think that trying to ask questions to clarify, because sometimes we don't know what story that's really showing us, right? And sometimes the underlying assumptions may not just be right. I was thinking, you know, sometimes you try to fix something, be it even a car, and you give it your best shot, but you sometimes have to change your effort. So sometimes, you know, to change that, trying one method and expecting that to be the only option may not fit this situation. And so trying to have a discussion like that. So I liked your suggestion of listening, finding out where it's coming from, and then trying to have the conversation.
And I would add to, you know, just validating, you know, the feeling, what you're hearing. Again, this is really hard. You know, I can't imagine what you're going through. And then continuing the conversation. But the validation, it sounds like sometimes, you know, we need to be heard. People need to be able to tell their story, and it's important.
Absolutely. Absolutely. A lot of truths get told in that time. This, you know, is a nice segue to this question. How can I know when it's appropriate to start the hospice conversation with my patient? I'm not in a hurry for him to go. What are some indications that he is ready to have the conversation? Jackie?
So one of the things that I think about, it was the question, the family's wanting to have the conversation with the person, or is it the provider? What was the question? The provider, or the when to have the conversation with your patient, right?
Yeah. And I'm not sure if this is a provider question or a family member question, but just, you know, when is it too soon and when is it too late?
Well, you know, the way I like to approach it is I like to approach it by saying, you know, I'm worried or I'm concerned that things may be changing. I see that you're weaker. You know, I'm seeing changes, and I think it's important that we talk about these things. I'm worried about what might be happening. And maybe we need to be thinking about, you know, next steps and how to plan and what kind of support we're going to need. But when you start seeing physical changes, weakness, changes in functional status, losing weight, all of these are things that come up that can trigger those conversations. I've noticed these changes in you, and I'm worried about it.
I like that. I think that's good advice. Now I want to ask to all of our panelists, what does hope look like at the very end of life? Like not 6 months before the end of life, not when there's still a third line of treatment, but when it's really right around the corner. To hope for a good death, is that really legitimate, or what does hope look like at that time? And maybe we can start with Monica.
I think particularly in many of your minority communities, you may hear them voice hoping for still, even if death is imminent, hoping for curative measures, hoping for miraculous healing based off their faith. For many people, hope may be, I'm just hoping for days without symptom burden. I'm hoping for time because it's this family event that I want to be present to. I'm hoping just to see my grandchild be born or to see my daughter graduate. So much of it is goal sort of oriented. And again, most of it is about relief of symptom burden, just some pain-free days where I can just go outside and just feel the sun on my face again when I've been inside for so long. Just days where I still feel like I'm a human being and I still have dignity attached to myself. Anybody else?
Thank you. Does that resonate with you, Ellen? Are those things that you and your husband thought about?
Yeah, I definitely was hoping that I could help him with the most dignified and graceful death that we could. And I was hoping that I could help him have the opportunity to say the things he needed to say and share the things he needed to share before his time was gone.
Thank you. Jackie, do you have anything to add about hope?
Yeah, I like to, as Reverend Monica was saying, when people are hoping for more time or for a cure or for, I like to reframe it. And, what can we hope for today? Like you're saying, can we have hoping for a good day today, hoping for, no pain, or hoping the pain goes away or it's better, or so what's in the moment?
Okay, and following on from that, on those good days, I'd love to hear your suggestions, and I'd love to ask the audience to type their suggestions into the chat. About what are some ideas for memory building and legacy making on those good days when you have time with your children, with your family, to say, this is what's been good, this is what I hope for you in the future.
So while we're waiting on people maybe to put something in the chat, I think that legacy building and memories and those kinds of things can be very valuable and very helpful and can bring closure in a healing way. And you can do it in so many different ways. I had a young woman that had children that, she was dying and they weren't going to have their mother. And so she wrote letters to them. And it was for every year of their birthday, she did a letter that they would be given a letter from their mother on their birthday. Here on the palliative care unit, we do thumbprints. It's called, hearts, and we make little thumbprints with hearts, and we just do different things. But legacy and those kinds of things, legacy building is important. I think it's healing and helpful.
Thank you.
I'm going to share that I asked Steve if he wanted to write some letters, and he did. He did write letters to dear friends and family, but he did sob through many of those letters, and I questioned whether that was worth putting him through that. So it's hard to know sometimes what's right for one person may not be worth what it's taking for another person. So there's no one answer, is there?
Yeah, I think, again, letting your person, kind of direct you. You've got to keep open ears and an open heart. Two suggestions in the chat. Making recordings of discussions if the patient is willing. They're precious when the patient is gone. And providing art kits for clients and family members during their cancer journey. I think sometimes, exactly, just giving people materials to work with. Often that's as you face this existential time, you start tapping into your arts and crafts self from decades before. So just having the materials available can make a big difference. Trying to talk about a sense of values that would be carried on for generations. Creating a small photo book someone created for their mother with brief messages about her life, who she was. And this was useful for the direct care providers to connect with her. which reminds me of our Meet My Loved One program here at UAB, which was something developed during COVID to really, in a very easy to access way to share information about your loved one with the people who are taking care of them at the bedside, especially at a time when families couldn't necessarily be at the bedside all the time. Okay, we have another question here. Please elaborate on the earlier question about living alone, transitioning to hospice, and the out-of-pocket expense. If hospice is free, is the patient not able to decide when to go into hospice to avoid these expenses? Important details, important things to understand. And I'm not sure I know the answer exactly. Jackie?
So tell me the question one more time, please.
Okay. Please elaborate on the earlier question about living alone and transitioning to hospice and the out-of-pocket expense. If hospice is free, we may need to start there. Is the patient not able to decide when to go into hospice to avoid those expenses?
Okay. So, great question. So as the patient, you're trying to decide if it's free, yes, can you make the decision to go into hospice? So there are criteria that have to be met. Your physician has to actually agree that you need hospice with a prognosis of 6 months or less. That is just a guideline that physicians have to use in order to make that determination. We don't always have the right answer, okay, when it comes to that, but you have a terminal diagnosis, you're no longer seeking aggressive or curative treatment, prognosis of 6 months or less. And if you, as the individual, feel like it's appropriate and you want hospice services, then certainly reach out to your physician or your healthcare provider. But you can also reach out to a hospice company and have a conversation. If you know a company in your community, and talk with them. They can reach out to your physician. But that is a good question.
Yeah, and I would say one of the things I worry about, and Ellen, I think you brought this up, is, what happens is it possible to enroll too early in hospice? And what happens if you wait too late? And I think sometimes when you get right down to the last days of life and you think it's going to happen one way, and then questions like this start cropping up, it can be incredibly distressing. And so that is one of the benefits of thinking about this earlier and upstream. So you can start to answer those questions at a time when it's not an emergency, time when you still have, some breathing space. So thank you. A couple more suggestions from the chat. Suggestion about using caringbridge.com to communicate with friends and family members. Gratitude to a new son-in-law for asking husband questions about how we met, bringing up good memories. And let's see.
And I see my colleague Nidhi Mahendra suggested the 3 Wishes program, which I have heard is a really wonderful resource. That's in the chat.
Terrific. Okay, we just have a few minutes left, and I'd like to turn now. I'd like to ask Ellen to help close us out by addressing a direct question about grief in the family and how to help children, who are grieving for the loss of a parent while you yourself are grieving the loss of a spouse.
Sure. I'd say please try to work with an experienced grief counselor who has so many tools and training to help navigate. It's a really hard situation, but there are people who are just wonderfully trained and really sensitive. There are books, there are groups, but I really think it's vital to work with a trained person. And maybe Monica can add to that.
Thank you.
So I
Reverend
would definitely join what you've lifted up, Ellen. By all means, look for grief support groups, look for grief counselors. Oftentimes, the chaplains associated with hospice can be of good support. The social workers can be as well. Just utilize whatever resources are available in your settings as well as within your community.
I think one of the most valuable things that I did for years when I worked in Texas was I volunteered as a camp counselor at a summer camp for children who had a bereavement in the prior year, and that brings together the threads of family and the community and support, both with the family and outside the family. And then the activities of, memory building, legacy building, putting together shadow boxes of memories, which I think sometimes it can feel too fraught to do that. And, is this the last week of your life, the last day of your life? But after some time has passed and they really are more memories rather than imminent grief, they can be a really powerful opportunity to share. So that I would recommend highly if you have access to one of the camps, even if it's a day camp. All right, well, we are coming to the end of our time. I want to thank all of you for joining us and for all of your generosity and the questions and the chat. Some really great suggestions there. We will make the slides available to everyone. We'll make sure that any unanswered questions get answered. And finally, I'd like to wrap up by thanking our participants, Monica Thompson, Jackie Palmore, and of course, Ellen Bernstein Ellis. Y'all have brought together a powerful story and a lot of information and knowledge. And I hope that this serves as a resource and a starting point for all patients who are living with head and neck cancer. So, thank you very much.